Hello everyone, and welcome to Dementia Basics. This is our third video. I'm wondering if you had more questions, such as what is the impact of dementia in the population? Or is there any treatment or research happening in our city or in the world to fight against Alzheimer's and dementia? The following presentation is by Dr. Neil Thomas. He's a researcher from Briere Research Institute and also professor from the University of Ottawa and a neurologist at the Memory Clinic. He's doing a lot of research regarding home technology and dementia. I highly recommend you to watch the whole video, the whole presentation, and understand those limitations that we have in research when we talk about dementia, as well as the multiple clinical trials and how those clinical trials are done in order to get a successful treatment for Alzheimer's. So I hope to see you all on June the 28th at 6 p.m. So get ready with your questions for the session. So have a good weekend.
Well, hello, and thanks for having me speak and give this presentation. So I'm going to be going over part 3 in this series, which the science of dementia, which is focusing on research and diagnosis of dementia and services in the area. But first I'll go through an outline of the other sessions that have been done over the past couple weeks by my colleagues. So in part 1, there was information that went over the aging brain. Part 2 went over dementia and defining chronic diseases and different types of dementia. And then, as I said, part 3 here, we'll be doing research and services in the area, talking about how a diagnosis of dementia is made, understanding the pathology and the underlying causes of dementia, advances in our diagnosis and treatment, and clinical trials that are being done in the region here. Okay, so first we'll do a quick review of parts 1 and 2 and just go over these briefly. So if we look at the brain, it's separated into different lobes, and each lobe has different functions. And so when we, which is important when we're thinking of problems with memory and thinking, because we can try to determine what area of the brain is affected, because we know over time we've been able to map out different regions of the brain that do different things. So when we look at the different parts of the brain that are responsible for different aspects of memory and thinking, hearing is generally represented in this part of the temporal lobe. Vision is represented in the back of the brain, or the occipital lobe, but other parts of vision are represented throughout the brain. Since we're very visual creatures, that takes up a good chunk of our brain as well. Executive function, that's in the front part of the brain, or the frontal lobe. And executive function is things related to problem solving, multitasking, and being able to divide our attention and do multiple things. And this is the part of the brain that is developed latest in life. So if any of you are wondering why some of your teenagers are maybe not making the best decisions and have judgment or have the best judgment, that's because this part of the brain really continues developing until early 20s or so. Language, very important as well, and it's represented generally on the left side of the brain in most people, and it involves in the parietal lobe and the temporal lobe. And what we call visual spatial function, so that's our ability to navigate around, our ability to form a mental image of our area and be able to navigate through the world is more in the parietal lobe, and vision is very important for that. And orientation, knowing the time and where of when things have happened, is also in the temporal lobe. So now we're looking at the brain. If we're looking right down the middle, And again, these are the different areas: the frontal lobe, parietal lobe, occipital, and temporal. And for Alzheimer's and dementias affecting memory, the temporal lobe is often the area that's most affected or affected earliest, and that's important for memory consolidation. And then our sense of smell is also, again, down here in the temporal lobe. So how do signals in the brain get sent? Well, they're sent through brain cells or neurons. And so we have electrical signals that are created in this part of the cell body. They travel down what's called the axon. And this is, you can kind of think of the wiring of the brain, just like we have wires connecting our electronics. And this is even insulated like those wires. So to allow the signal to go quickly through the neuron and the axon, there's sort of insulation around the axon as well. And so at the end of the axon, we have little projections that then will connect close to other cells, and that's how a signal is sent. So there's initially an electrical signal sent through the neuron, and then at the end, little chemicals are released, and this is a very small microscopic space, and then those chemicals either send signals to promote signals going through or to inhibit signals in the next neuron or brain cell in the chain. And so, you know, we have hundreds and hundreds of billions of neurons and multiple connections. So each neuron connects to, you know, hundreds or thousands of other cells to help send signals through the brain. The blood supply to the brain is very important. There's a lot of blood supply that goes. It takes up about 30% of our metabolic rate, and blood because of the vast needs of the brain. And so there's a very dense wiring of circulation. And this is often obviously important for things like if someone has a stroke, because that can affect memory and thinking when one of these blood cells gets blocked off. As well, one of the things that is impacts and causes dementia is narrowing and hardening of these arteries over time. So unfortunately, you know, as we get older, we do lose brain cells over time. So you have the most brain cells when you're first born as an infant, and then you know, brain cells die over time and are not significantly replaced in the brain. So it seems like a lot. As I said, 500,000 brain cells die each day, 20 million per year, but that's only an annual reduction of 0.1% of this total of billions and billions of neurons that we have. But you know, over your lifespan, that is about 10% reduction in the number of brain cells that you have between the age of 20 and 90. So when we look at getting older with this loss of brain cells, although there's more strengthening of connections and we do continue to learn all the way through our life, there are certain aspects of memory and thinking that do decline and slow down over time, unfortunately. So there's certain things that we're not able to do as well in our 70s or 80s compared to our 30s or 40s. And so that is expected to change. So with normal aging, so this is just looking at different aspects of normal aging versus mild cognitive impairment versus dementia, and I'll talk about those in a second. But with normal aging, we have mild changes in memory, language, executive function, so it might take us a bit longer to solve problems and go through different tasks. We can't maybe keep as many things in our mind as before. We might have more of those times when you walk into a room and you're like, oh, why did I go here? But those shouldn't have a major impact. And our IADLs are instrumental activities of daily living. So paying bills, driving, working, those sort of things shouldn't be affected, and that should remain stable, even with these mild changes. With mild cognitive impairment, that means problems with memory and thinking that don't have a significant impact on your day-to-day life, but are more than expected for normal aging. So there will be more significant or noticeable changes in memory or language that the person is suffering from mild cognitive impairment or their family members or friends may notice. But again, the activities of daily living should remain fairly stable. You might be a bit slower at things, but you're still doing them independently. And then finally, dementia means problems with memory and thinking that are more than expected for age and significantly impact your day-to-day life. So with that, we will also again see significant changes. Generally over time will be in multiple aspects of memory and thinking. And then you are going to have a decline in instrumental activities of daily living and eventually more basic things like dressing, feeding, those sort of things much later in the disease. And so this is really a continuum. Someone who develops dementia or Alzheimer's disease, this doesn't happen overnight. People that are developing problems and who eventually develop dementia will progress from normal functioning to mild cognitive impairment to dementia. Now, in people who have mild cognitive impairment, it can be thought of as a risk state for progressing to dementia, but not everybody that develops mild cognitive impairment will go on to develop dementia, but it is a higher risk. Some people do return back to normal, and that's generally if something like a medical cause or another medical condition was found to be affecting cognition, and then it's treated. But in general, the risk is that people will go on to continue to have problems and may develop dementia over time. And again, a slow, gradual progression in people developing things like Alzheimer's disease. So there's this idea of learning and unlearning. You know, when we are born, there's a little few things that we can do, and we learn the very basic things, just holding our head up, paying attention, focusing on a single word. Then it becomes more complex, walking. We start to understand more and learn language and learn words to say. Our fine motor control improves. We might learn, then we learn to speak in sentences. Then going to school, you start to learn to read. Eventually to, getting or acquiring all of the skills we need to manage our day-to-day activities and, managing your full-on life and budget and work. The idea with dementia is that there's a process of unlearning. So it's the things that you learned latest in life that are lost first. So, people will start to have problems maybe at work or with more complex things, managing their day-to-day budget. Bills might be missed or mispaid. They might have more difficulty remembering to take medications. And then it's that stages of unlearning that happens. And dementia progresses over time, where it's the more basic things that are lost much later in the disease and only at a severe stage. But you can kind of think of it as progressing backwards through those stages that we learned as we were growing up, and it's not a normal part of aging. So dementia is an umbrella term. As I said, it generally means problems with memory and thinking that impact your day-to-day life. It's not a specific disease. And when we say umbrella term, that's because lots of different things. There's many, many different potential causes of dementia. So the most commonly known and one we think of most is Alzheimer's disease, but that's only one form of dementia. There are other types of what we call neurodegenerative diseases, so diseases that affect the brain over time, such as Lewy body dementia, vascular dementia, meaning affecting the blood vessels, and then other medical conditions like a large stroke or a brain tumor could cause memory problems or dementia as well. So with Alzheimer's disease, there are certain changes in the brain. So what happens is we have proteins in the brain. They become abnormal over time, and that's these amyloid and tau proteins. They then start to kind of clump together, and they can become toxic to brain cells and kill off brain cells over time. So that's the general idea of what's happening in Alzheimer's disease. We have the amyloid plaques that build up outside of cells, and the neurofibrillary or tau tangles that develop in cells. As we've learned more about Alzheimer's disease, although it's one of the most common causes of dementia, if we look, what's really the most common form of dementia is a mixed dementia. So generally there may be Alzheimer's changes, and people will generally have other things going on, such as vascular disease. So that's a very common thing to be co-occurring or sort of worsen the changes that we see in Alzheimer's disease when there's little blood clots or narrowing or hardening of the arteries over time. So you can have a large stroke where a big blood clot blocks off a big artery, and then you have tissue death over time, or there are just small arteries that get blocked off and contribute to vascular disease, and that contributes to slowing of memory and thinking over time. Frontal types of dementia, so frontotemporal dementia, again, this is a neurodegenerative disease. Proteins build up and kill off brain cells over time. But unlike Alzheimer's, the more common early signs are large changes in behavior or personality. So people might become very apathetic, meaning they're not motivated to do anything, they have less drive. They can become quite inappropriate and uninhibited. They may overeat, they may do repetitive behaviors, and then they have more deficits in things like planning, judgment, insight. And it's a bit more likely to have a genetic link or a family history. There's the grouping of frontotemporal dementias. There's also the language variant that affects the temporal lobe more. As I mentioned, that's the area of the brain that's more important for language. And this, you can have more difficulties with aphasia, and that just means problems with language. So word finding or non-fluent, agrammatic, really effortful speech. Or semantic dementia, you lose the meaning of words. So people start to not only have difficulty finding the right word to say, like saying, oh, that's that thing that I used to write with. Oh yeah, it's a pen. Eventually people actually lose the knowledge of what an object is. And there's a lot of difficulties with comprehension as well as naming objects. Lewy body dementia is generally dementia associated with Parkinsonism. It's similar underlying problems to Parkinson's disease, but it affects more of the brain than the deeper part of the brain that we see affected in the movements in Parkinson's disease. It's a little bit different as well there is Parkinsonism in most people with this disease, meaning slowness and stiffness of movements, but there's also visual hallucinations. There can be quite noticeable fluctuations in people's level of consciousness, or they have periods of confusion and then they seem to revert to almost normal. There's REM sleep behavior disorder can be associated with Lewy body disease, and that means people who are sort of reenacting their dreams. They move around a lot at night. They may roll around, kick and punch and things like that. And unlike Alzheimer's, where there's more memory problems, visual spatial functions, navigation abilities, attention are more affected in Lewy body disease. Parkinson's plus diseases, we now know these are more linked to the abnormal proteins and the frontotemporal dementias or frontotemporal lobar degeneration, and they will impact executive functioning. They can impact language, and there's often signs of Parkinsonism or abnormal movements, again, slowness and stiffness of movements, abnormal tremors in different types of movements, and generally people have more difficulty with visual spatial elements. And they can have depression, but it's really more related to an apathy, so a lack of motivation, that these people seem to stop sort of caring about doing things. Although it's called Parkinson's plus, so the more that we've learned about it, we now group it in the conditions related to frontotemporal lobar degeneration because of the abnormal protein involved in these, and they're fairly rare. So now I'm going to go over how a diagnosis of dementia is made. And so what do we do day in and day out in the memory clinic here? So we see people with concerns about memory and thinking, and this is a good case as an example of that. So then we have a patient who's a 77-year-old female that is coming into the clinic. She starts just by, coming down, forgetting why she went into the basement. She's not worried, but her family's saying, well, we're noticing this a lot more. It seems more to just be the occasional memory lapse. There's a more pattern of problems. It seems to be progressing gradually, and they're noticing more changes in her memory than her husband or than her friends or peers of her age. It's starting to now have a difficulty or impact on her day-to-day life. So her husband's noticing, well, she's paid the wrong credit card bill or paid the wrong amount. She maybe missed paying a few bills, and that's happened more than once or twice. Sometimes she'll go to the store and buy things she doesn't need, and so double buying of items. And then her husband's now had to take over some of the chores because she's not able to do that as well. So that's a history where we're seeing changes that I would start to be worried that there's more problems than just what I'd expect in normal aging, and it's starting to seem to have an impact on day-to-day functioning. It's very important here that I always ask to have a family member come to these appointments, and it's really important that someone accompany a family member to a medical or doctor's appointment when they're having concerns about memory, so they can provide some collateral history, because the person may not notice or may not have insight into the changes in their memory. So it's important to look and see if there's a family history. So for this example, this patient's aunt had dementia, no history of stroke or vascular disease in the family, because having a family history of Alzheimer's does slightly increase your risk. It's not a guarantee, but it's definitely something we look for. Social history, so higher levels of education can be somewhat protective, and it's good to know what level of education someone finished, as well as what they did during life. So we'll get information on their social history. So the lady finished high school, she worked as an administrative assistant and raised a family. Medical history, so she has mild osteoarthritis and a hysterectomy, so very little other medical history, but this is also important to see if there's other conditions that could affect or be impacting memory and thinking, such as if she had a history of stroke, that would be very relevant. So when we look at, and group together the cognitive issues, it seems to be problems related to mostly memory. She's having problems with sense of time, so, remembering when things happened, and some word finding difficulties. Her cognitive testing, so now that we've established there's some concerns about memory based on history, there will be, we generally would we'll do memory testing. So this is pen and paper testing. And in this case, this is a test called the mini mental state exam. People may have also heard of the Montreal Cognitive Assessment, which is a very common assessment to be done as a screening test for memory problems. So she scored 23 out of 30 on the mini mental state exam. And that's lower than expected. So that again raises concerns that not only do we see history and self-report of memory problems, but also there's objective testing that's now showing problems in memory and orientation. For physical exam, so there's nothing unexpected, and when we say no asymmetry here, that means that there's no weakness or numbness or other symptoms on one side of the body compared to the other, and that's important to think about because something like a stroke would generally affect one part of the brain, and that would come out with problems on one side of the body versus the other. But generally, the physical exam and neurological exam will be normal in certain types of dementia like Alzheimer's. Laboratory tests, again, also important to do to make sure we're not missing other medical causes. So things like untreated hypothyroidism, vitamin B12 deficiency, other medical conditions could affect memory and thinking, and we want to treat those if they're present. And then we are going to get some brain imaging, like a CT scan of the brain or an MRI of the brain. And that is in part to see if there's any more excessive shrinkage of the brain compared to what we'd expect normally. And also, is there any evidence of vascular or blood vessel disease that could contribute to dementia or something unexpected like a tumor that would be treated very differently. And so that's good to get a baseline to make sure we're not missing anything else that would be treated differently. This person is taking medications, and it's also very important to get a review of medications because certain medications can affect memory and thinking. So in this case, this person is on a medication called amitriptyline. It's an antidepressant medication. It's used for sleeping in some people, but it actually can have an effect in people, slowing down memory and thinking a little bit. It's not necessarily a cause of dementia, but could worsen symptoms people are having, or for people even without dementia could cause people to feel a bit foggy and slow in terms of their memory and thinking. And the reason that this may have an effect on someone, so one of the brain chemicals that we think that is low in Alzheimer's disease, this medication acts on the brain by blocking that chemical a little bit. So that could also, worsen things in terms of how someone's experiencing their memory symptoms. So looking at the whole picture together, problems with memory and thinking that have progressed gradually, affecting mostly memory, but also orientation, and now starting to affect day-to-day activities. And so that would fit with a diagnosis of dementia. And then we have to look and see what would be the most likely cause. And with that pattern of deficits, dementia related to Alzheimer's disease would be the most likely cause there. And again, Alzheimer's and other dementias now are generally a clinical diagnosis. We can't be 100% sure without actually a piece of the brain that would be generally obtained on autopsy. And obviously, we don't do those tests during life. So we make a clinical diagnosis based on the symptoms that we're seeing, the history, the results of cognitive testing, the aspects of memory and thinking that are affected, and other signs on the neurological exam and things like that. So how are we going to treat this? Well, we're going to wean off the amitriptyline because, as I said, it blocks one of the brain chemicals that we're trying to boost. And actually, that's what this medication, donepezil, so it's a memory medication that's approved for use in Alzheimer's disease. It actually tries to boost that brain chemical. So obviously, we wouldn't necessarily want to be doing having medications that are counteracting each other. So replacing with a different type of sleep aid, which has its own side effects, but is likely is potentially a bit better tolerated and doesn't have that effect on the brain chemical that we're trying to improve with the donepezil. Again, we're going to follow up once the medication started to see how the person tolerates this. So donepezil, the most common side effect is stomach upset. And so this person did have mild nausea for a couple of days, but generally that'll improve over time. And then we're going to monitor cognitive changes over time to see how do they respond to the medication, what's the trajectory, how someone's changing over time with respect to their memory and thinking, but also their daily functioning. And then future planning. So it's really important to look and see, are there any safety issues? Is the person cooking and leaving the stove on? Are there any problems with navigation? Do they seem to be getting lost at all? And then future planning to think about how are we going to support this person as their condition progresses, provide support for the family, provide support for the person with dementia as well, and think about what they may need going forward. And a big part of that is often a referral to the Dementia Society so they can provide education, support, and help for the person with dementia and their loved ones and family. Okay, so now I'm going to move on and talk about the underlying pathology a bit of Alzheimer's and disease, and really go into a little bit of research and some of the challenges here. So as I mentioned, dementia is an umbrella term. It's not one disease, and that makes it much harder to study and treat, if we're dealing with lots of different causes. So, there can be similar cognitive consequences, meaning problems, that people are developing with memory and thinking that are impacting their day-to-day functioning. But it could be due to different causes overall. Because it's such a complex disease and the brain is still a very complex organ to understand, the exact cause, and when we say pathophysiology, that's meaning the underlying changes that's happening and how the brain is functioning. It's not completely understood. And so we've learned a tremendous amount of how the brain works, but there's still lots of things that we are trying to figure out. And then another potential challenge is that, when we test a drug and say we have a drug that we think will clear out those plaques and tangles in Alzheimer's. Well, as I said before, the most common cause of dementia is a mixed dementia, meaning it may not just be those Alzheimer's changes in the brain that are causing causing the disease. So it may be that the drug is tested in people, and if it affects or improves one aspect of the disease, it might not affect something else. And the other difficult part of that is, although we're fairly accurate and we have a good diagnostic accuracy, especially in a memory clinic for diagnosing diseases and saying, okay, that's most likely related to Alzheimer's disease versus that's most likely vascular disease or frontotemporal dementia, it's still not perfect. So when we're testing and enrolling people in trials, when you test it on a group of people, there may be some different conditions. So we can't just treat dementia in general. We have to start to pick out and say, okay, we're looking at treating something that's going to be more likely to treat Alzheimer's disease or vascular disease, which can hamper and make drug trials a little more difficult if we're not enrolling the exact specific people that we want. So the other challenge is, again, it's not one disease that's affecting things. And when we're trying to test a medication, again, it would be ideal to treat and test a medication in someone with one problem. So when there's lots of comorbidities, and this means other medical conditions. So as people get older, they're more likely to have other medical conditions, high blood pressure, high cholesterol, arthritis, diabetes, things like that. That can also make things complicated for when we're trying to bring someone into a clinical research trial, where we'd like to be able to say, okay, we're going to treat this one thing, try the medication, and see if it improves that one thing. So a good example of that would be, trying to develop a new medication to treat high blood pressure. If we took a group of people who only had high blood pressure and no other medical conditions, we test them with the drug, and the people who are getting the drug versus the people who are getting the placebo or the the sugar pill, sort of, that is going to be the best sort of way to test that. And we can say, okay, if that drug seems to work in the people who are getting the real medication, maybe that's really good for treating hypertension. But since there can be other factors that affect high blood pressure, then when we are trying to do a treatment in someone who might have, the high blood pressure, but also diabetes, heart disease, and other things that might have an impact on that, it's just not as easy to know all the effects of those other things. And then the other thing is we have studied a lot of these conditions in animal models. So we've made animal models of different cancers, animal models of Alzheimer's disease, but it's never a perfect reproduction of what the actual disease is in humans. And so generally, as I said, it's much more complex, where it's not just one simple disease. We can make changes in the amyloid and tau, those proteins in the brain in Alzheimer's disease, in animal models, and sort of give mice those changes that are going to cause degeneration in the brain, and then try to see what drugs will treat that. But that doesn't simulate all of the clinical symptoms that someone's going to experience with Alzheimer's disease as a human, and because of the changes in our brain. So things, lots of promising drugs that have been great in animal models and basic research have gone through large clinical trials and unfortunately not shown a disease-modifying effect or an improvement in Alzheimer's disease or other diseases in humans. So the other thing that can be very difficult is that the clinical symptoms that appear, so when someone actually starts to show the changes related to dementia and Alzheimer's disease, it may be decades after the first changes that are happening in the brain. So a good example of this is, and something we know fairly well, is it was some disease like Parkinson's disease. So that affects a specific part of the brain that's involved in initiating and making fluid and normal movements, and it's deep in the brain. It is due to one type of cell dying off over time. And when enough of those cells die off, we finally start to see changes in the slowness and stiffness of movement that come with Parkinson's disease. But that is generally around when more than 80% of those brain cells are already lost. So you can see the problems with, if we wanted to intervene and treat that disease, probably where we're going to have a good effect, when someone's only lost 20% or 50% of those neurons, it is very difficult or impossible to detect, really, because that person is not showing any signs or symptoms of the disease until much later. And there it might be almost too late to make a significant difference when there's that much change. So that's another challenge that has been there. And that's probably a similar thing in Alzheimer's, that changes in the brain that are starting may be happening 5 years, 10 years, even 15 years before the diagnosis and the memory symptoms start to show up. So when we look, there's not one single uniform way to talk about these diseases, and likely there's not going to be one drug that cures dementia. But I don't want you to come out of this thinking that it's all sort of all hope is lost and we're not looking at these things. There's lots of research that's going on, and the more we learn, the more we can actually start to treat the different things and start to say, okay, we've looked at trying to treat these changes in the amyloid tau, the amyloid plaques and the tau tangles. And there's been some unsuccessful trials to this date. But the more we learn, we start to say, okay, well, maybe that's part of it. We need a drug that helps that. But maybe we also need a drug that helps reduce inflammation, a drug that helps keep the blood vessels healthy and reduce the risk of stroke and vascular blood vessel disease. So, those sort of things are really important. And we're going to make advancements when we understand all the different things that can cause dementia. So this talks about, again, that problem where it might start in one area. So it might start in the brain or in the actual cells of the brain, but then it seems to progress. And so, maybe the start of buildup of amyloid in the brain is that first sort of spark that starts things going. But by the time the symptoms appear when someone has the disease, it's not only that there's that buildup of amyloid and tau, but maybe that's driven other changes, such as, the amyloid might have effects on the health of the blood vessels. And so you're going to get, more hardening of the arteries, or that's happening in people at the same time and they're working together to cause problems. That can lead to things like inflammation, and that can start to affect other brain cells. So we have the neurons, which are the main brain cells, and maybe that's where things start. But then things like inflammation, buildup of these toxic proteins like amyloid and tau might start to affect other support cells in the brain. So astrocytes are sort of support cells that provide nutrients and keep the neurons healthy. Microglia, you can think of are kind of like immune cells in the brain. And we are starting to see that they may act a bit differently depending on in some people. So it may be that amyloid builds up and then microglia cause inflammation or killing off brain cells, and some people more than others. So there's more things going on, and there's this progression of disease before the symptoms start to be evident to someone or their family members. And again, it may be affecting more than just the brain cells themselves. It might be affecting other parts of the brain and other support cells. So that is kind of what I talked about here. You might have the individual proteins starting off the problem, but that might lead to things like inflammation, leading to more loss of neurons, leading to impaired transition or signaling between cells. And then when that's impaired enough, then you start to see the cognitive changes or changes in memory and thinking in day-to-day life. And eventually those cognitive or memory and thinking changes lead to functional changes, so problems with your day-to-day activities. And again, these are progressive in nature. There's things that happen as we age, so it may be hard to target one thing, but looking at all of this together, we may have insight into more things that we can treat, and maybe the treatments for dementia are going to be looking at promoting exercise, healthy lifestyle, improved diet. All of these things might reduce inflammation, keep our blood vessels healthier, and then we're looking at other drugs that are going to clear out those abnormal proteins that are building up, as well as things to keep the blood vessels healthy and reduce inflammation and things like that. And that's, again, where we get this pathological cascade, or this loop of what happened first. Is it the inflammation that starts the amyloid to build up, or is the amyloid that starts the inflammation? And again, nobody knows the exact answer to that, but it's probably a little bit of both. And we probably reach a certain state of what we consider dementia in different paths for different people. But it seems like certain things seem to drive other changes, and so people with amyloid buildup and tau buildup will have higher inflammation in the brain, and then in those people that have other things like blood vessel changes, that can drive unhealthy changes to neurons, more neurons dying off, and more amyloid building up, and things like that. All right, so again, this is a lot similar to what I've talked about. We might diagnose dementia later in the disease, but if we could start treatment when there's very little damage to brain cells, there's little changes that have happened, that might be the time that we would make a bigger difference. So with the drugs that have been tried to clear out amyloid, a lot of those have unfortunately failed, and it may be that similar idea to, as I mentioned, with Parkinson's disease. If you've already lost, there's already been lots of brain cell loss, and we've had changes in the brain that way already. If we clear out all the amyloid, the damage may be already done. So once someone's reached a point of dementia, it may be difficult to reverse those changes. And so we start to really need to look at ways, how can we detect things as early as possible? How can we detect subtle changes in memory and thinking that need further investigation? Because maybe if we were starting these treatments earlier and saving more brain cells over time, we might have a modification on the disease process itself and slow down the progression of changes in memory and thinking. All right, so now I'm going to go in and talk a little bit in general about, when we're looking at research and trying to evaluate things that we read in the paper and all these new studies coming out about things that are associated with memory loss and dementia and Alzheimer's disease, and trying to tease apart a little bit about what might be a cause, because there are differences between when two things are associated versus when we say one thing is definitely going to cause another. And so when we look at certain research in the media, a lot of it pulls from what we call non-randomized studies, and I'll talk about what a randomized study is in a bit. But these are observations where we follow people over time, and then we see, when you have 1,000 people and you follow them over 20 years, a certain number of people will develop dementia. And then you start to see, okay, well, what are the things that are in those people, but not as much in other people that might be associated with developing the dementia. But the important thing to think of is just because something's associated doesn't mean that it is necessarily the cause. So a correlation is not a causation. So causation indicates that one event is the result of the occurrence of the other. So an easy way to think about this is like an infection. So something like tuberculosis is caused by a tuberculum bacteria. And we've, looked, there's been lots of research over time, and we've well determined that that's the bacterium that causes this specific type of disease. When we look at something like dementia, there's lots of different things that could be impacting it. It's a little harder to determine causation, but that's where we have to be really careful to say, that when there's an association, it doesn't automatically mean that the one thing that we're looking at is necessarily going to be the only cause or the cause of the change. And so a good example of this is a really strong correlation. And so you can, see a lot of things might associate. If you measure enough things together, you might find association. So this is a really strong correlation. You can see whatever these two things that we're measuring are quite tightly linked over the years. But then when we look at what they actually are, well, it's US spending on science, space, and technology. And so in red versus suicides by hanging, strangulation, and suffocation. So again, this shows a very strong correlation. So we could just think, okay, this could be associated, but really when we think about it logically, it's unlikely that there's a cause behind these. So the other kind of funny one that I've seen in different jokes about this sort of thing would be, if we look at global warming, if we look at the temperature of the Earth, that's been going steadily higher and higher and higher. But if we look at the number of something like pirates in the world, that has been decreasing over time. And so there's a negative correlation, but I wouldn't think anybody would say, well, the decline in the rate of pirates in the world is a cause for global warming. So how do we make sure or try to make it a better idea of if something is an actual cause of the disease that we're looking at? And how do we make sure that that association is not just by random chance or because of a bias in the research that's being done? So the way we look at that is the gold standard is thought to be a randomized control trial. And this way, we're hoping that the subjects being compared differ only in their exposure, either to a medication or to the intervention that we're considering. So, in this way, this is how most drug trials work. Where we're going to, give some people the true medication, and then other people are going to get a placebo or inert or inactive medication, and then we're going to see, does this have an effect? And the way that sort of works is it balances the groups. So all the other things that could contribute, you're not going to get them stuck in one group versus the other. So let's say if we designed a trial and we were looking at a history of stroke, and we wanted to see, does this medication help treat stroke? Well, we might we might have a lot of difficulty if we put in one group, everybody who has a lot of blood vessel or vascular risk factors. So reasons they might have unhealthy blood vessels. So if they're, all the people in one group are the smokers, people with heart disease, people with high blood pressure and diabetes, those are all risk factors for unhealthy blood vessels, and could be a cause of stroke. They're more likely to be having a stroke later on in life, and if everybody else in the other group is fairly healthy, then that's not a good sampling between the two groups, and there's more likely in one group that that event is going to happen than the other. So if we're trying a drug, even if the people in the group that have more of those risk factors for stroke get the active drug, maybe we don't see an effect because they're just more likely they're going to have a higher risk of stroke regardless. Or again, if we're trying to find associations between something that might be a cause of a disease, again, if the groups aren't well balanced and one group has a whole bunch more comorbidities or other factors that might cause the disease, then again, we're not going to get to the correct results, because if we say, okay, well, in this group, there were more smokers, and so smoking is a cause of stroke, well, that's true, but maybe the other things were bigger factors like the heart disease, the high blood pressure, and the diabetes. So that's a difficult part. So again, as I said, half the participants will receive the true treatment, half the participants will receive the sham treatment in a randomized control trial testing a new drug. And then it's also important that neither the participant nor the researcher knows who gets what. And that's called a double-blind experiment. And again, this is meant to avoid any bias. And it's not that researchers are trying to be underhanded or may want to do something on purpose to promote a drug. But if you knew someone was getting a treatment, even unconsciously, the people doing the rating may start to think, well, maybe that person seems a little bit better, seems like their memory's a little bit better. So it's really important that the people getting the drugs, they don't know if they're getting the one that's active or not. And even the people doing the assessments, they don't know, does that person on an active drug or not? And that's really just to make sure there's no unconscious biases that might be coming in that we're not aware of. And then you look for the differences between the two groups. And what we can say is if the groups are well matched, so there's an equal number of people that are smokers in the group, the one group not getting the medication versus the group getting the medication, and those risk factors or other things are well balanced in the groups, then we can say, well, the only thing we've really changed is they've gotten that medication or not. So we can say that's probably a real effect of that medication. We can be more confident that that's something that's going to be effective. So then when we look at observational studies, that's when we kind of draw inferences about the effect of an exposure to something, and then we look at people over time. So you might either look at it two ways. You might grab a group of people and say, I want to take 1,000 people and see who develops dementia and what are the risk factors for that. And then you're going to measure a whole bunch of things as you're following these people. You're going to ask people about, are you a smoker? What's your diet like? How much sleep do you get? What's your level of education and things like that. And then we look to see, okay, well, in the one group, in the group of people who ended up at the end of the study monitoring period developing dementia, there were certain things that were associated and more likely to be a cause of this. And again, that can now give us some information that can allow us to do more research, but it's really only picking up inferences or associations. So it can't unfortunately give us a causal link specifically, but it starts to say, okay, well, those are maybe a few of the things that we should really be looking at. And a good example of how this might be a problem is when you look at, say, nutritional research. So I can think of two ways. So either you could maybe only look at one thing. So let's say we're going to look at people who are more at risk of a heart attack or heart disease or this medical problem later in life, and we're going to do look and say, okay, I want to see, is it more likely the people who ate fish have a heart attack later in life or not? Is eating fish a better diet? And if you only measured that, and then we could say probably at the end of that, okay, it seems like the people who ate fish more in their life, they had less chance of heart disease, less chance of stroke, they seem to be healthier overall. But if we didn't measure anything else, well, maybe it's not just the fish. Maybe the fish is just a marker or associated with a healthier lifestyle. So maybe, when the people that are more likely to eat fish on a more regular basis, well, they're also more likely to eat vegetables, or maybe, their meals that they're having with fish, well, the other people were more likely to have a really high fat diet. And so it's not necessarily the fish itself, but it's maybe the absence of having a high salt, high fat diet. And so that can be a problem if we don't measure enough things. Or on the other end of things, if we just measure everything, then, by chance, because we're not measuring the changes in every person in the whole world, we're always getting a bit of a sample. So this is a sample of people who wouldn't completely represent the world that we live in as a whole, because you're just by chance going to get, more of certain things versus others. And then if we just measured as many things as we can think of, and then start looking to see, well, eventually, because it's not a perfect sample, some things are going to pop up, and nutritional research can be an example of this. So when you look at studies that measure lots of different things, we might get an association with one study that says, okay, eating dark chocolate is really good for heart health. And then the next study says, well, no, there was no difference. It didn't matter if you ate chocolate or not. And then another study says, well, eating chocolate's actually bad for heart health. So that's where we're measuring potentially a lot of different things, and because each sample is slightly different than the other one, that's maybe not a true causal relationship as I talked about. It may just be an association that we're picking up, and that's when we need to go on and then do more rigorous and further studies. So these are very important studies, and a good example of this would be how we developed the link between, or how we determined the link between, let's say, smoking and lung cancer. So obviously a randomized control trial is great if you can ethically give someone an intervention. So when we're trying a new drug, the idea there is that we're saying, we've tested this in animals, we've tested this in other people. Now we really think, it seems to be safe. We perceive, or we believe that there's going to be a benefit for these people taking this drug. So if I, test this drug and it gets out and now it can be used in the general population, we're going to lower the risk of dementia, or we're going to treat hypertension better. But there are certain things, obviously, that ethically as researchers we can't do. So again, the lung disease and lung cancer and smoking is a good thing. You could never do a trial, and you would never want to think about doing a trial where you would say, okay, we think there's an association between lung cancer and smoking, so we're going to make a whole bunch of people smoke, and then ask a whole bunch of other people not to smoke, and just see, does the group of smokers get a higher risk of lung cancer? So with these sort of other observational trials, we were able to go back and say, okay, now we've gotten a pretty strong signal here when we follow people over time, and when we take a whole bunch of people who develop cancer, and we take a whole bunch of people who are around the same age with other medical conditions, but they didn't develop lung cancer. Well, one of the things that consistently comes out in study after study is the people with higher rates of lung cancer had higher rates of smoking. And eventually a causal link can be determined, but that takes larger studies and more evidence to show. But again, it's certain trials we just can't do a randomized control trial. So as I said, overall, it's less reliable. We can get associations, but not things that are definitively a cause. But it can lead to, it can start to pick up things that we couldn't have studied otherwise and wouldn't have picked up. And so it can lead to these important discoveries. As I said, like a good example like that, determining that smoking is a significant cause and risk factor for lung cancer. So advantages to both of these, we use them in different situations, but really to determine whether a drug trial is working, or to say that association is really, this is a cause of dementia, we need more rigorous and often randomized trials. Okay, so when we now want to look at advances in the diagnosis, so what are we looking at? And as I mentioned, we now want to start to try to figure out what are the changes happening in dementia, and we want to pick them out as early as possible, potentially even before people are showing major signs. So if amyloid and tau are proteins that we think there are certain versions that are bad in the brain, how can we measure them? Well, very fortunately, our brain is actually very well protected in our body, and it's actually somewhat sectioned off from the rest of our body. So things that come through our blood, our arteries and veins, they actually get met with a blood-brain barrier, so this, certain chemicals and different things that are in our brain or in our blood can't get as easily into the brain. And this is a protective mechanism. So certain, drugs and toxins and things like that are sort of kept separate from the brain. But that makes it much more difficult when we want to access and check on how the brain is doing. So there is an area or fluid that is very deep on the inside of the brain, and also kind of is around the brain and allows the brain to kind of sit in the skull, and that protects it somewhat, but it also is a marker, and we can see, a measure of how the brain is doing. So it's much closer to what's actually happening in the brain than our blood. So being able to measure that, we can only get this cerebrospinal fluid or spinal fluid that is around the brain and around the spinal cord by doing more invasive procedures like a spinal tap. So there we can get a bit more information. We can start to see, are there abnormal levels of this amyloid and tau? But doing a lumbar puncture or a spinal tap is a bit more invasive. It's not comfortable. It's a very safe procedure, but again, it's not as simple to do as just drawing blood. We have to insert a needle into the area between two vertebrae or bones in the spine, below where the spinal cord ends, which is about halfway down your back. And then we can pull out spinal fluid and test it. So then there's been ways to look at how else can we see if there's these abnormal amyloid and tau proteins in the brain. Can we measure it in a way that's not as invasive as a spinal tap or measuring spinal fluid? So for both amyloid and tau, we're starting to figure out these radiologic tracers. So we can inject a certain molecule into the blood vessels, one that has to be able to penetrate through that blood-brain barrier, and it can get into the brain, and then it can actually tag or stick to abnormal versions of the amyloid and tau. So just to tell you, normally everybody has amyloid and tau. They're very important proteins for the brain, but it's when they become abnormal and clump together and become toxic to brain cells that we see changes in Alzheimer's disease. So people have started to look at ways, well, can we measure this with a scan or a different way? So with amyloid scans, you put in this, as it's called, an amyloid binding tracer into the blood. It goes into the blood vessels and then eventually into the brain, and it sticks to the abnormal amyloid in the brain. Then we can do a certain type of scan called a PET scan and measure how much of this tracer got into the brain and tagged certain molecules. So when we say control, we mean someone who has normal memory and thinking, so normal cognition. And you can see in people with normal cognition versus people who we have clinically diagnosed with Alzheimer's disease, or the way to completely validate this type has been by actually going to autopsy and saying, okay, the people who had Alzheimer's clinically that we diagnosed and also had uptake of this tracer in their brain, we can confirm that that was actually tagging to Alzheimer's because they have higher levels of amyloid. So what you can see here is the people that are controlled, they don't really have high levels of amyloid, the abnormal amyloid in the brain, but this tracer can start to pick up people who do have that, even in stages before dementia, so when they have a later level of mild cognitive impairment. We can also start to see that with tau. So this is the same kind of process where we inject a radio tracer that will latch on or attach to abnormal tau. And in people who are remaining cognitively normal or healthy, there's very little uptake or very little attachment of this tracer. And in people with Alzheimer's, you can see higher levels of tau. So this is exciting because now we can start to see in people during life the actual changes that we're assuming are happening in people developing Alzheimer's disease with this buildup of amyloid and tau. So that's a great thing to be starting. We don't use this in the clinic yet. It's still very expensive. It's also generally used just in research. It's not 100% like every test. So some people, as I mentioned, do go throughout their life and they develop higher levels of amyloid in their brain and they never might develop dementia. So just having a positive amyloid test without other clinical symptoms isn't enough to say this is a diagnosis of Alzheimer's disease. So you need the whole picture together. But it is something that has helped with some of those problems I talked about when we're trying to figure out, okay, are we more likely enrolling people in this trial that we're going to test a new Alzheimer's drug that clears out amyloid? Are we enrolling people who are more likely to have amyloid in their brain? And now we can say yes. And so, we're going to put people in the trial who have a positive amyloid scan or a positive tau scan because they're more likely to have underlying Alzheimer's disease and not vascular dementia that looks like Alzheimer's disease. So again, these are very promising techniques used in research right now, and very helpful to hopefully develop drugs that are going to be useful to treat this disease. Other ways that we can do that are not as invasive are using things like an EEG. This measures brain waves and brain activity. And so here we have these brain waves here that we can see. And so again, a healthy control, a person with normal memory and thinking, and we're comparing them to someone with problems with memory and thinking that are more than we'd expect for the normal aging process, so mild cognitive impairment. And so normally we can present someone with a stimulus and there's going to be a response in the brain waves detected on the EEG. And so there, you don't need to know what these mean exactly, but there can be these P2, N2, and P3 waves. And so here you can see this is what normally happens. And then in what we found in certain trials is people with mild cognitive impairment may have a delay in this activity. So again, this could be something, if it's fairly specific to people developing problems with memory and thinking, that could be a less invasive way of detecting changes or slowing down of memory and thinking. There's computer tests that we're testing as well. And so that's looking at different tests that we can do that kind of replace some of the pen and paper tests that we do in the clinic. They could be potentially done on the computer in places outside of the clinic. And they're being looked at to see, can we look at computer-based testing to detect changes that are there in memory and thinking that are a sign of dementia or cognitive impairment. The last thing I want to talk about is I did talk about this blood-brain barrier, but it's not absolutely perfect, and an even more recent finding, and something that would be very helpful if we can validate this test, is they are starting to look at blood tests that can detect abnormal levels of amyloid and tau. And within the last year or so, we were getting some even more promising results to say that some of the blood tests are starting to have a fairly similar accuracy to these amyloid scans. So these blood tests would be much less expensive. They're less invasive than a spinal tap or lumbar puncture. And so they may be able to give us information that gives us that little bit more extra information to support our diagnosis of this is dementia due to Alzheimer's disease versus another cause. So again, promising research, things that are coming out, still only used in research. More work needs to be done to validate these and say they're really working and they're going to be effective, because we don't want tests that are showing false positives where we're saying, okay, this looks like you might have Alzheimer's when there's not amyloid changes. So we have to be very careful and test these very rigorously before we move anything into the clinic space where we're testing people in public. We are also looking at other ways, like using technology and home-based monitoring. So that's some of the research that I do, looking at measuring things related to daily activity, daily sleep, medication use, computer use. All these sort of things might be able to show us changes in function that are important for your day-to-day life that are declining in people with memory problems and dementia. And again, maybe ways we could pick up things early in those functional day-to-day tasks that you're doing. So advances in treatment. So again, this comes back to how do we develop a drug? How do we go from what we call preclinical testing, so animal model testing, laboratory testing, testing on petri dishes and animals. That's the first part where we start to see, okay, we have an animal model of Alzheimer's disease, or we're testing cells that are affected by, brain cells affected by Alzheimer's disease grown in a lab. What are the potential drugs? And we're testing, lots of new drugs to see what are ones that start to show they're able to clear out the amyloid or tau plaques. They're promoting the connection and health of brain neurons. So generally we'll do laboratory testing, and new drugs that seem to be promising we'll start to test in animal models. And then things that show promise in animal models, we then move on to a clinical trial. So there's years and years and hours of testing in this, what we call preclinical testing, that involves laboratory tests before a clinical trial's even started. And then we get to the actual clinical research, and this is again very rightly so a very rigorous process. It's long because of that. We need to enroll lots and lots of people in these tests and test for drug safety being of the utmost importance, and then obviously the effectiveness of the drug. So once we start to see, and this process can take years and years, on average even a decade or 15 years before we might see a drug move from the first trial to being actually able to be approved by Health Canada and used in the general population. And it involves thousands and thousands of research volunteers usually. So it's generally split into 3 different sections. So we have phase 1, phase 2, and phase 3 clinical trials. The first trial is often around what we call dose finding. So what's the effective dose that we can give? We want to find out the highest effective dose that's not giving side effects. So the first part is really given, generally it's healthy volunteers, so people who don't have the disease we're interested in, but how do they respond to the medication? We'll test how the medication is metabolized and broken down in the body with blood tests. And then we'll also very carefully look for side effects and what could be potential side effects of this medication that weren't seen in the animal research. And so then once we find a dose that seems to be effective and is not causing significant side effects, then you move on to phase 2 trials. So this we might look in 20 to 100, a few dozen healthy patients. And now we're going to start to move into tests with people who have been diagnosed with the disease. And now start to see, okay, not only is this safe in people, but is it actually showing beneficial effects? So does it seem to have a signal that we start to see where there's an improvement in the disease? So it lowers blood pressure in people with hypertension. It improves memory and functioning in people with dementia. And then again, now that we're testing more people, we're still watching closely to see, are there any side effects that would make this intolerable or not a good drug that could be used? So if these tests show promise, so it seems to have a beneficial effect on the people getting the medication and there's not worrisome side effects, then we move on to the phase 3 trials. And I guess, another example to use here is the COVID vaccine. So that's a big thing people would be thinking about right now. And some of those have finally started phase 3 trials at a very accelerated pace, faster than most research has ever worked because of the importance of this. But now we're in a stage where we've started to see, okay, well, in some people it seemed to work, it didn't cause really bad effects. And now we do the efficacy. So is this medication actually showing a benefit? And if there are treatments out there, we're going to compare it to standard treatment. So again, you don't want to just look at it developing a new blood pressure medication if it's just going to work as well as the dozens of blood pressure medications that are already out there on the market. If you're going to develop a new drug and it's going to be marketed and sold and potentially for more money than current drugs, you have to show, okay, that's actually better than what we really have. There's no point in coming up with something that's just as good as what's already out there. So you may compare with the standard of care. And if there is things like, unfortunately, with dementia, if we have limited medications, then we may look at just comparing people on the medication versus not. It's going to be conducted at multiple locations throughout the world. So the research trials that are here are often done here at the Briere Research Institute and Briere Hospital, as well as multiple sites throughout Canada, the United States, throughout the world. We're looking at thousands of patients, and there we want to really see, is there a difference in the people getting the medication versus those that are not getting the medication? And that's where there's lots of medications right now that are still being tested for Alzheimer's that are in these phase 3 trials. But it does take long. It's with thousands of research volunteers, and generally takes years before we'll see the beneficial effects of this. And as you've seen in the news, potentially with the COVID vaccine, that safety monitoring is continuing to occur through phase 1, 2, and 3. And occasionally, if there's an unexpected or unexplained problem or that comes up, or side effect potential side effect that comes up, that's going to cause things to be halted or really reassessed to see, do we think that this is just someone got a headache because people can get headaches, it doesn't have to be due to the drug, or is this something that is linked to the drug and as a side effect we have to now look and see, is the risk outweigh, or is the risk more than the benefit that this drug might have? So then once all of this has gone on, and if it goes well, and for thousands and thousands of drugs that are tested in preclinical phases, we might get one that's actually effective and comes to market and is approved by Health Canada. So if all goes well, then we analyze all the data, we ensure that the therapy or drug is safe and that it's showing this, that it's effective and doing what it's supposed to do. And then there's the final analysis. and starting to say, okay, is this better than what's out there? Is it just as safe or safer than what's out there? And is this going to have a beneficial effect for patients? And then it starts to be used regularly with ongoing follow-up, again, looking to say, are there no further safety effects? It's, it'll go to be approved by Health Canada, and then there's going to be continued testing to see, now that someone's been on this drug for a year, for 2 years, for 3 years, we want to make sure there's no new side effects that are coming up that might have been unanticipated, or longer term side effects that weren't seen earlier on. So it's going to be continually tested to make sure, people that are in the general population now that are taking a medication in a less structured fashion than a research trial are still benefiting from it, and there's not new safety issues or side effects that are coming up that are worrisome. And again, so this takes several years, 10 years to 15 years, could be from preclinical to this point here where a drug is actually approved. And unfortunately, a lot of times when we hear these very promising results, it can be even very early on in phase 1 or even preclinical studies. So, we've done a lot to treat diseases really well in certain animal models, but that doesn't always translate. So just hearing something about a drug that has improved cognition or improved blood pressure or reduced stroke in animal models, we need to go through all this very rigorous long testing to make sure it's beneficial in humans, because a lot of the time, unfortunately, we see very promising results here, but then when you actually test it in people in more complex situations, it doesn't help, and it doesn't work. So it's very important when you're looking at those reports that you're seeing where this information is coming from. And so as I already mentioned, we've had, unfortunately, not as much progress as we'd like in treating amyloid and tau, so stopping the production of this. So we're trying to remove these abnormal proteins using antibodies. And the idea here may be that, some of the drugs that have been quite effective at removing the amyloid, and tau drugs are now much newer, but they are being tested. But the drugs that have been effective in removing amyloid, potentially, the treatment's too late. So there's already too much change that's happened in the brain, and we can't totally reverse that. Having said that, though, there are still promising trials that are coming up. People may have heard of the drug aducanumab, and I bring it up because it's in the news a lot. It was a trial of, again, a medication that removes amyloid in the brain. It seemed to do that very well. There was a bigger trial going on. It had two sort of arms to it, two trials within that. One of the trials seemed to show a potential benefit, and then another trial didn't show a clear benefit. So with that sort of conflicting evidence, we're now back to a stage where it's in another phase 3 trial. It's really being tested really rigorously. Again, we're probably at a point where we have to wait a bit more time, another year or so, or even potentially a bit longer before the results of that trial are known, and to see, is it really effective? Based on the analysis we had from the unfinished prior 2 trials, they have applied to the Federal Drug Administration in the States for approval for treating Alzheimer's. Again, we'll see what happens with that. It would be great to say we have something that might be beneficial, but what will likely happen is, because those earlier trials were stopped, those other trials were stopped early because it seemed like initially the medication wasn't effective, we're going to need more evidence to say that this is really effective and not causing significant side effects in people. So again, some promising news, but unfortunately nothing that's going to be changing in the short term, but potentially in the near future we'll have some good results and good information from that. Okay, and sorry, so I did bring this up earlier. I forgot this slide was coming up. The other thing that we're doing is looking at some home monitoring tech. So this is a new way that we're trying to look at how dementia may present. And so we're seeing that changes in lots of variable things. So activity level, walking speed, medication taking behavior, using the computer, how much time you spend out of the home. If we look at all of those together, we can start to find changes that might be related to a decline in cognition and specific for changes related to dementia, and maybe a way to detect things very early, follow people over time, and then you can compare you to you. So we get a baseline of how someone's doing, and we can see, are they staying the same, getting worse, or are there any changes over time? And so something that might be promising for testing new medications, for detecting dementia and following it over time, and then potentially providing some feedback to people. So that's another area that we're interested in looking at. Can we tell people, okay, you're missing a medication, or a calendar helper because people are not getting to their appointments and things like that. So eventually we might be able to take this home monitoring technician and move it more into a feedback system, sort of smart home that can support aging in place, and allow people with memory problems to stay at home independently longer. Okay, so clinical trials in you. This is just going to give a little bit of information about what's happening in Ottawa. So within the Briere Clinic and the Briere Research Institute, we are doing lots of different types of trials. So there are drug trials where we're testing new drugs, things like that aducanumab medication are being tested here. Intervention trials where we may try an intervention that's not a drug. So maybe that's a program to help people with dementia or their caregivers, certain types of or different ways. It's not necessarily a drug. So there's a trial right now looking at would light, sort of infrared light shone into the skull and into the brain, would that be an intervention that slows down or helps keep connections in the brain, slow down changes related to memory and thinking, and promotes or stops progression of brain cell loss. Technology trials, as I just showed you, that sort of home monitoring system, we're working on ways to validate this information and try to find out ways to really say that this is effective and helpful for people. And to do that, we need to show that this can measure what we want it to measure and follow changes over time. And then also just longitudinal disease progression trials. So those are things like the Canadian Longitudinal Study on Aging, and these are very important observational trials where we can start to determine those associations that I was talking about that you can pick up in observation trials. So we follow people over a long period of time and then start to pick out what are the more likely things that are happening in people who are going to develop dementia. So are there changes in diet, changes in their lifestyle, other diseases that are more likely to be associated with developing dementia later in life, and can we then study those a bit more closely. So how does someone get involved in research? So generally, there'll be certain criteria for each trial. And so there'll be screening tests that are done to see with volunteers or people who are patients, if they're interested. People seen in the clinic might, will be asked about, are you interested in participating in research? And then they may be contacted later on. Our clinical trials unit can also be contacted about interest in research for volunteers, either that are healthy or people suffering from mild cognitive impairment or dementia. So those are ways that we try to recruit people into trials. There'll be baseline testing. So you start out and see how you're doing now. There may be an intervention like a drug or a technology system or other things that are being tested. And then there's follow-up testing at regular intervals to see, are the people that are getting the intervention, are they getting better? Are they, is it slowing down the progression of the disease, or does it not seem to be benefiting? So there's always this follow-up testing. It's important to compare the intervention that we're interested in to someone who's not getting that intervention. And that follow-up testing can happen at different intervals. Generally for observational trials, it's less frequent, but for things like drug trials, there'd be more visits where people would come in for testing and then for receiving the medication as well. So if you are interested, you're able to contact our clinical trials unit and see if there's things that we always appreciate, and that's the only way we're going to move forward with this research. We very much appreciate our research volunteers and realize, doing this, it's you're giving something of yourself. There's time, you're taking medications, you're trying things. So, this is the only way that we'll make research move forward. But we're very appreciative of people who show interest in these trials if you're able to. Okay, so that's everything that I wanted to go through today. Thank you very much for your attention and going through things on these this new type of virtual platform that we're having to use now. And so I'd be happy to take any questions now.
Right. So thank you, Neil, for this presentation. Let's see if we have any question from the audience. I think we got a question. Oh, a comment. Amazing presentation. Thank you.
Well, thank you very much. No, I appreciate that, and I do enjoy sharing the information. I think these sessions that the Dementia Society run are really valuable, and it's helpful to be able to provide this information to people in the public. So I'm happy that I get this chance to provide a bit of information for people out there.
So Neil, I have a question. So do you guys have trials for mild cognitive impairment?
Yeah, so there's trials, and that it changes all the time. So the best way to get more information is to contact our clinical trials unit, and you can find that on the Briere Research Institute website, or just by looking up Briere Clinical Trials Unit. We do have trials that are enrolling everywhere from normal memory and thinking, so healthy volunteers, to people with mild cognitive impairment, to people with mild dementia. So those are trials that we are looking at, and I believe some would be enrolling right now. And you have to meet certain criteria, but there are ones that look for people with mild cognitive impairment.
Right, thank you. So one question here. My father is in the hospital. Can he engage in clinical trials?
So, not knowing the whole circumstances behind that, what I would say is generally, so clinical trials done in settings such as the memory clinic here and an outpatient clinic, it would generally be involving people who can come in at different intervals. So they wouldn't be transferred from the hospital to do trials. So that would often be a limiting factor, at least for a lot of the trials we're doing here, the clinical trials unit here. Having said that, within the hospital, I know Briere is very supportive of research, the Ottawa Hospital as well. So certain research trials are done in the hospital setting as well. It's obviously a very different setup and a different group of patients, but there are some trials that are being done, testing things, either processes in the hospital, treatments, different things like that. But each trial has a different inclusion criteria for people who can enroll. For most of the trials that are being run at our institute, being in the hospital would be a reason you likely couldn't be in the trial. But it would, it's still reasonable to always check and see, and also look at opportunities that might be there in the hospital as well.
Okay, it seems that we don't have any more questions here. So thank you, Dr. Thomas, and this presentation will be also available on our YouTube channel. Thank you very much for tuning in. And next Thursday, October 22nd, at 5 p.m., we will continue our series with Part 4, Understanding Behavioral and Psychological Symptom of Dementia. For more information on education programs and support, visit our website, dementiahelp.ca, or register for our weekly roundup. Have a good evening, everyone, and thank you.
Thanks, and I just want to say, the question about are there more of these, so that's in this session. There's more of these sessions run through the Dementia Society, so it's a great opportunity to learn more about dementia. All right, thank you very much for your time.